Hello, everyone. I'm Dr. Rita Roy, CEO of the National Spine Health Foundation. Welcome to Spine Talks, where we bring unparalleled access to world-class experts like the doctors who are joining me today. I'm here in LA at the NASS meeting, and we are delighted to have experts joining us to speak about the very important topic of bone health and osteoporosis. I'm delighted to be able to turn the program over to our moderator, Dr. Tom Schuler. Tom?
Thank you, Rita. Bone health is such an important subject that we have to pay attention to make sure that we live our best lives. And here we are at this international meeting. We're blessed to have experts with us who are spine experts, spinal surgeons with a special emphasis on bone health and bone metabolism. So Dr. Dymar and Dr. Carlson, if you could introduce yourself to the public.
I'm Dr. John Dymar. I'm from Louisville, Kentucky, at the Leather and Spine Center, and also a professor at the University of Louisville.
Dr. Brandon Carlson. I'm at University of Kansas in Kansas City. I'm an assistant professor there.
So let's talk about bone health. That's what the subject's on. So if you gentlemen could just help the public understand, what do we mean by bone health and why is it important?
Well, when we talk about bone health, we're talking about the general status of your skeleton and how what its overall condition is as far as strength to support your body and provide metabolic function in your body. And it's a really important aspect that you should consider, particularly when you get over the age of 50, whether you're male or female, because it has some things that change dramatically as you get older. And we have really been trying to educate the public a lot to be aware that this is part of your overall health and that you need to include it when you go to your doctor and other specialists to decide whether or not you need potential treatment for diminishing of the strength of the bone and overall function of the bone as you age.
So what about the skeleton? Why do we even care about it?
Yeah, so it's so critical. I mean, it's the infrastructure of your entire body that keeps you supported in the world. And what's interesting is most people don't even understand that their bones are turning over constantly. They're changing, they're evolving. As different patients or different people age, and different genders are different, they age in different ways. The bone is changing in a way where it's actually losing some of its bone mass. So think about the structures of your skeleton are just getting weaker and weaker and weaker. You don't really feel it. It's not painful. It's not something that you would know to look for. And what's interesting is if you don't look for it, you're going to end up with a problem, and that's what we call osteopenia, osteoporosis. Those terms are just definitions of how weak the bone may have become. And it's really a definition of how at risk is that person for a fracture. And that's what we're really focused on is how do we maintain that skeletal structure to its optimal position in life so that we can prevent fractures.
I think ever since humankind started walking upright, we ended up with more risks and more problems. And so keeping the spine strong as well as all our other bones, whether it's the leg bones, the thigh bones, your arms, all those things to avoid fractures are critical for your health and well-being, because once you have a fracture, that impairs your mobility, which is then a huge trickle-down problem and all sorts of other health issues. So I'm a little biased as an orthopedic surgeon, but I think that the spine is essential for life. And even if you don't have it, then the rest of the systems don't function so well. So it's important to understand that. We used a term osteopenia and osteoporosis. Do you want to define that for the public?
Well, just a few basics if you're out there and going to listen to this. We add calcium to our skeletons till we get to be about 28 to 30 years old. And that's when the period of the bone is strengthening. After that, you lose a certain amount of calcium every single year for the rest of your life, so your bone is always becoming weaker. And that really tends to get worse by the time you're 50 and up into your 80s. Women generally tend to lose it quicker than men from age 50 on, and after menopause, for example, you lose 4 or 5 times your bone mass over the period of menopause, and that gives you a big head start. But men do catch up with women by the time they're about 80 years old. So we really have to start worrying about bone health when you're very young. Stay active. You can only add calcium till then, but all of our treatment really is to slow down the loss of that bone over your lifetime. So when we talk about osteopenia, that's a period of time when your bone is starting to lose calcium and get somewhat weaker, but it's still structurally strong enough that you can carry on most daily activities. But it's a warning sign that if it continues, particularly when you get to be in your 60s and 70s, it's going to get worse and worse where your bone gets weaker and weaker, and you develop osteoporosis. And we have a lot of very specific tests that we can measure that with that are available to tell you whether or not you're in that category. One other thing to consider, that if you have other comorbidities or other illnesses, we call it, they can vastly accelerate the progression of osteopenia and osteoporosis. For example, if you have diabetes, or if you have particularly renal disease or some other syndromes, all these things can make you lose calcium more quickly throughout your lifetime and result in developing these problems even earlier. So those might be red flags you might want to consider in your 30s or 40s, might affect your bone as you get older.
So one of the things when we talk about this bone bank of the skeleton, it's an annuity program. You got to put the calcium in when you're young to be able to withdraw it as you get older. But subject comes up with patients all the time about, but my calcium level is normal. My blood calcium level is normal. So how do you answer that?
Yeah, I mean, my mom has osteoporosis, and I had to try to explain it to her. And I think just to really simplify it, calcium's in your blood at all times. And it's critical for all sorts of muscle functions, heart functions, organ functions. And your body will tightly control that calcium level at all times. So at a single snapshot, when you get lab values, it'll be normal. But where it gets that calcium is from your bones. And that's where over time, if you don't have enough calcium in your bones, or you're losing that calcium, it's taking it from there. If you're not getting it from your diet, you're going to get it from your bones. And that's where that sort of slow leaching process off the bones, the skeleton, can result in loss of bone density. And we talk about density and quality, and that's sort of an in-depth concept. But if we lose the density over time, that's when we reach the categories that he's talking about, osteopenia being the weaker bones, and osteoporosis is the most weak category we have, where the risk of fracture is extremely high. So the calcium level in and of itself is just one piece of the puzzle in how we analyze bone metabolism. There's a lot of hormones in our body that control it. There's vitamin D levels, et cetera. But that's sort of where a clinician, hopefully a surgeon or maybe a primary care or an endocrinologist could sort of deep dive into each patient, make sure that they look at all those factors together, piece it together, and make sure that the patient has the optimal picture for their bone health at their age.
But I think the critical piece of information for people to know is that a normal blood calcium tells you nothing about whether your bones are strong, whether you have osteopenia or osteoporosis. And it's critical to understand that. Just a common misunderstanding that I hear almost daily in clinic. And it's important for people to understand that that's it. John, did you want to add?
And it's exactly right. At all costs, the calcium will be maintained in your blood. And it's at the expense of your bone bank, which you've been adding calcium to your whole life. So that's if the calcium gets out of whack, for example, it can affect, as Brandon said, your heart function, your muscle function. So your body will always maintain a normal calcium level at the expense of your bone bank, which is your skeleton. So the importance of adding to that skeleton as much as you can with exercise and a good diet and calcium and vitamin D3, which we'll talk about, throughout the bone building period, the stronger and the more deposits you have in that bone bank, the longer you're going to go without having bone problems, unless you develop some other illness. It'll just simply mean that you start at a higher point. And we see that with different kinds of people actually have much higher density in their bone when they hit that 30-year-old mark, and they'll less likely to have fractures of their hip or spine as they age in their 60s and 70s. So it's very critical that we pay attention to that pretty much from when we complete growth as teenagers.
I think just to recap what you're saying here, people generally think that osteoporosis is something that you think about when you're older. And I think one of the things that we're here to talk about today is that bone health is something that you need to think about throughout your lifetime. Dr. Schiller, you said it really well. It's an annuity. Dr. Dymar, you're talking about the bone bank. Dr. Carlson's talking about how it's the body's reserve to keep calcium levels high because calcium does so many other things for your body. But osteoporosis is not something that we should only think about for postmenopausal women or for the elderly. Thinking about bone health as something that you build in your younger years because it helps you throughout your life is something that's just really important for us to really drive home. And I'm so thrilled we're talking about that today in terms of keeping your spine healthy to keep you moving through life. And putting those pieces of that puzzle together are just really critical.
Motion is life. And when you have broken bones, you don't move so well. So it's to avoid the fractures. So what I'd like to talk about right now is how do we make our bones stronger up till the age of 30? If we can talk about things that people should be doing generally to improve their bone health up to the age of 30, or approximately when the bone starts to slow the deposition of calcium and minerals into it.
Well, just briefly, a healthy lifestyle. And unfortunately, I'm going to have to tell you that you need to quit smoking, which has a very high association with osteoporosis and osteopenia.
Why?
Well, there's a lot of different factors, but it seems to affect the bone metabolism, and you just don't really add calcium to your skeleton. It slows down that process, and smoking has over 3,200 various chemicals in it that all are carcinogens and nicotine and a lot of other things, and they just generally decrease your bone becomes more catabolic. In other words, you lose bone than if you didn't smoke. Another thing that can cause severe bone disease is drinking too much alcohol. Being an alcoholic, absolutely, those patients will have significant bone problems because it affects your liver, which is critical to making bone. Your body's a very fine-tuned machine, and everything affects everything else. So if you have liver or kidney disease, it's going to affect ultimately how strong your bone is and everything. So those are two big things you can stop. Part of having osteoporosis is genetic. Believe it or not, there are certain people that will be predisposed. All you got to do is ask your mother or father and see if they've had fractures that will be predisposed to having osteoporosis. And you should start much earlier in your life doing proactive changes. So there are just three important things you can do to maintain good bone health that are relatively simple as far as us explaining to you, but sometimes difficult to address in your lifestyle. What do you think?
A lot of people think of bones as being sort of these static sticks in your body, so to speak, and they're not. They're made of living cells. Those cells actually respond to stimulus. What I mean by that is walking, impact exercises, gravity loading the bones actually stimulates the bones to stay healthy and to maintain their calcium deposition. For example, my cousin is a quadriplegic. She was in a motor vehicle accident, never walked after she was 18. It's tragic, right? But she doesn't load her legs. She got severe osteoporosis in her legs and broke her femur with just lifting her leg up to move to another chair. It's because the body isn't loading all the time. So sedentary lifestyles are a predisposition to losing bone mass and losing bone density. So more activity and walking and staying active and axial loading on your spine and axial loading on your bones can help. And it's a funny trade-off because my orthopedic colleagues, they'll say, well, that's going to make your knees wear out and your ankles wear out and stuff. But it can be simple as just walking and making sure that we have gravity loading on the spine at all times throughout the life cycle, and that keeps the bones healthy.
Those are lifelong things you should do, not when you start when you're 70. You have to do those your whole life. And loading the bone makes it stronger. So that's why one of the key things we recommend for somebody with osteopenia for sure is to do physical activity because it slows down bone loss.
It's interesting. The astronauts go to space, they lose bone mass when they're in space because they're not getting stimulated. Yeah. And one of the things we note is that the ability to strengthen your bones happens because of a really cool fact of the bone, the cells that make bone, the osteoblasts, is that they're stimulated by pressure or force. And so that walking, that loading, weightlifting, all those things are stimulating the osteoblasts, the cell that lay down bone to make more bone. And so that's why it's so critical. So we talked about a lot of things that people should avoid or that they can do, but we didn't talk about diet. Let's talk about diet. So what diet things are important?
Well, it depends on where you live. I'm sure this video will be seen by people in places where nutrition may not be possible or may not be optimal. I think that probably in most cases, Americans have pretty good availability of nutrition, and most things such as fruits and vegetables have more than enough calcium in them to basically keep you healthy. Vitamin D is critical to absorbing calcium from your intestines and also regulate it within your body. So vitamin D3 specifically sometimes is deficient. And where you see that a lot is, for example, people that don't have sunlight. You have to be outside to make it in your skin. And that caused rickets back in Europe during the turn of the century, the 19th and 20th century, because children would never get in the sun, wouldn't have it in their diet, and basically would end up getting rickets or bowed bones because they were so soft. So certainly there are certain people that may be deficient, that may need vitamin D3 supplementation. So that could be also in your diet, that's why it's in milk. It was put in there in the 20s, basically because of so many children had vitamin D deficiency. So you could actually check your vitamin D3 levels, and if there are low, and some people just run low levels for reasons we don't know, you could take supplemental D3 that's available at the pharmacies over the counter and boost that up to keep it at a high range enough that you can, help absorb the calcium from your intestines when you eat it. So that's variable among people, but those are just two of the dietary things that you can do to improve your health, bone health status.
Yeah. I'll just echo on the calcium in particular. Calcium supplements or calcium pills are okay, but we know now they're not absorbed very well. And so calcium from the diet is far better. The other part is that the D3, we've seen this big paradigm shift in probably the last 10, 15 years, where we're very averse to sun exposure, possible skin cancers, things like that. So people wear more clothing, their skin is exposed less. The glass in our cars and our buildings is all UV coated now, and that blocks the ability to get UV rays to the skin. So we know that, especially in winter months, the D3 levels in everybody's bodies, ours included, goes down a lot. People that have indoor jobs where there's no windows, there's no sunlight, even with coated windows, they don't have as high D levels. So those are the patients that silently for years, they're having really low D levels and they're losing that bone mass without them even knowing. It's taking 10, 20 years for it to really amass, to show its face later. But at that point, it's too late. That's, I think, the point of this panel is those are the critical things you should focus on. And maybe when you're younger, even though you don't think you're going to have osteoporosis, check your D level in the winter. See if it is low and maybe get a supplement going. The D levels, or the vitamin D supplements are very safe. They're absorbed extremely well. And a general practitioner or any sort of surgeon, and they're cheap. And we can prescribe them very simply. They're over the counter. So.
Yeah. There is a vital study that was done where they looked at people taking vitamin D, and people that had normal levels do not benefit from taking more vitamin D. It's not going to prevent it more. And it was a cost issue. So they recommended those people not take extra vitamin D. But if you test low for it, you probably ought to consider doing it or getting more sunlight, for example. A famous bone expert came into my practices, which is 9 orthopedic surgeons, and said, I take it every day. And so we all checked our vitamin D3 levels. And it turned out we all were low. So I can tell you right now, there's 9 spine surgeons in my group that take vitamin D on a daily basis. So that's how important. Just a simple thing like this can change your whole future as far as years down the line getting fractures that may be quite disabling for you.
So what foods are best sources of calcium? I know we were general, but can we make any recommendations about foods that we think are good?
Well, you're not going to like it, but like cod liver oil is the classic one. That has very high levels of vitamin D, and it tastes terrible. But you can certainly take a vitamin D tablet individually. You can take it in a multivitamin. You could take it in. There's a wide variety of foods, and we can provide a list for you on the website that will tell you what has high vitamin D levels if you're low,
and calcium levels too,
or calcium levels. But a lot of times, by the way, calcium citrate is by far absorbed better than calcium carbonate, which is Tums, which doesn't get absorbed very well. The calcium citrate is better absorbed, but there's a whole list of different foods you can eat, but sometimes they're not very palatable, and I think then you have to eat larger quantities of it. The reason why you take a teaspoon of cod liver oil is it's very concentrated in vitamin D3. So generally, most foods there's a lot of foods that have supplements of vitamin D3, a lot of different vitamin preparations available, and of course, there are some oral supplements you can take as far as food.
What about calcium?
Calcium, I mean, you can think of the classic ones, right? A glass of milk, any sort of yogurt sort of supplements. There's calcium fortified juices. Some of the different green leaf type salads have actually pretty high calcium levels. So you can seek out things that you could add to your diet each day. And again, the most recent recommendations that I follow say that any sort of sourcing calcium from your diet and not a supplement, even though the supplements you just mentioned are the best ones we know that are absorbed, the diet provided calciums are much, much better in terms of maintaining that intake and make sure it gets absorbed.
But generally, a good healthy diet, you'll be able to get enough calcium in your diet if you eat vegetables and fruits. They have a lot of calcium in them also. Yeah. Most normal diets in the United States don't require necessarily calcium supplementation unless you have a proven problem with calcium absorption. Remember, if you're taking antacids, they lower the acidity of the stomach, which slows calcium and vitamin D absorption. And so that may be an indication for taking some supplements or using calcium citrate.
Yeah, I think that's an important thing because most supplements, if you look at them, are calcium carbonate. Right. And as Dr. Dymar said, calcium citrate is absorbed better because it's absorbed across a broader array of pHs. And so having calcium citrate as your supplement, if you're taking a supplement, I think is important. So the easy mnemonic for me on that is just to say, hey, it's like citric acid, it's like eating fruit. So if you're thinking about it in your store, which one do I want? You go, I want the one that's like fruit. So it's calcium citrate as opposed to calcium carbonate.
And there's a chart. It's not the same for everybody. If you're a pregnant lactating woman, there are charts that say you should be taking a higher dose of calcium, for example. And there are also a lot of other different diseases where you might want to take more. Like, for example, if you have some intestinal diseases, you don't absorb calcium or vitamin D3. Mm-hmm. So we can provide a chart on the website that basically will show you what the recommended doses are from the federal government.
So we've talked about bone strength and about how to build your bone, how it's important. How do you actually measure bone strength? What tools do we have to measure the bone strength?
So it's a big, to really understand the bone, you have to understand that there's density, which we can measure, and there's quality. And that's very difficult to measure. We don't have a great methodology for that yet.
What's the difference in those two terms?
Well, density shows how much actual hydroxyapatite per a given volume.
So mineral, how much mineral?
How much you got it. So yeah, no medical jargon here, but the stuff that makes up the bone is called hydroxyapatite. It's a structured, layered mineral deposit. And if we can measure that amount of hydroxyapatite per volume, which is standardized in our healthcare world, that's a density. And that's what, like a DEXA scan, a bone scan that people get to measure for osteopenia, osteoporosis, is measuring a bone density.
And what is a bone density test that you're describing?
The DEXA. Yeah.
What describe that?
So it's a two-dimensional simple X-ray. You lay on a table. It can be done in a clinic, and they shoot an X-ray usually of your hip, or your wrist, or your spine. It can do all three of them. If you have total hip replacements, they won't be able to shoot the hip, but they have to be able to shoot the beam through the bone. And then there's a box they put on it, and there's a clinician that will interpret that value, and then they convert it to a number. That number we call a T-score. T-score is what we all measure and kind of go off. And really what it represents is, as we kind of started the story, it's measuring you back to the bone density of a normal, healthy female, correct?
At age 30.
At age 30. So it's the amount of bone density we expected in a normal, healthy 30-year-old female. And how far away from that have you become? How many deviations away from the norm have you become? It's a statistic. Without getting too complicated, the number might be minus 2.0. And that's when I'll ask my patients in clinic, hey, do you remember what your T-score was the last time? They're like, minus one, minus something. And that's what it's representing, is how many deviations away from the normal 30-year-old bone are you? And that's going to then be quantified based on a big population study of how many people had fractures. They quantified those categories to then say what is osteopenia and what is osteoporosis. But that is purely based on density. It's not a measurement of quality, and those two together, it's a very complex topic that there's probably an entire session on at this meeting, and that's probably beyond the scope of this conversation. But what the doctor can measure is density, and that's where we make our diagnoses. There's a couple other methods where we measure density, but the gold standard and what you would get done at a primary care office when you're 35 or 40 or 50 years old is a DEXA scan. And wouldn't you agree that that's the mainstay? That's what I order for my patients. That's what we can track because it's reproducible, and it should have a very similar read from one to the next if you're doing it on the same machine.
There are three ways we can look. Bone is flexible. Like I could take a femur and bend it a little bit. So it's made out of
strong
collagen. Collagen is what makes up your soft tissues. And within that collagen, what he was talking about, we deposit calcium. And that stiffens it up. So if I have a liver disease, for example, if you're an alcoholic, I don't lay down the good flexible part of the bone. And so it's not good bone. That's what we talk about when we said osteomalacia. Most people don't have that unless they have one of those risk factors. So really what we're looking at is just how much calcium stiffens up the bone so it's more rigid so we can walk on it. And that's constantly happening. Your bone actually remodels your entire skeleton every decade. You're going to have a new skeleton. And when that slows down and gets replaced by osteoporosis or some disease, that's when you start to get softer bone. Okay, so that's kind of briefly about that. But when we talk about osteomalacia, that's usually associated most commonly with liver disease and alcoholism and things along that line. And the other thing we could do, the DEXA scan is a gold standard. If you have a family history of risk, you probably ought to get one done when you're 50. Okay, and generally, if you have any sort of fracture of your hip or spine, then that automatically means you most likely, according to a score we call the FRAC score, that you just fill out in the office, some offices do that, automatically means you probably have osteoporosis. And so those are the common methods. The third way is, believe it or not, we can do a surrogate or a kind of a standby look at your bone. If you ever get a CAT scan, we have the ability to go look at the bone in the CAT scan and actually measure certain units we call HU units. We also can determine whether there's a likelihood that you have osteoporosis. And then we can, of course, if you haven't had a DEXA scan, order one to confirm it.
Do patients have to worry about radiation exposure on the DEXA scan?
Very minimal.
Exceedingly low.
It's like 0.001 rads or millisieverts.
Which I don't even know what that means, but I do know it's
I'm going to tell them.
It's lower than a general chest X-ray, and so the exposure and the life limit of radiation exposure, it's exceedingly low.
For the audience, in simple terms, is if you get a CAT scan, it's like 10,000 times more radiation.
Yeah.
So that should never be done as an initial screening for osteoporosis. You should get the DEXA scan because it's relatively low risk and low radiation exposure, which is a problem lifelong.
And can patients just ask their doctor for a DEXA scan? Is that something that you can walk into your doctor's office and say, I'd like to check my bone density. Can I get a DEXA scan?
I think the answer is kind of.
Okay.
Right?
I'd be a little more, after listening to this discussion we've been talking about, I would say yes.
Yeah.
I think if you're over 50 and you have a family history and you're a female and you're worried about it, I think that you can request a DEXA scan because just like you're going to a diabetic, you're going to say, hey, doc, can you check my A1C or my glucose level?
Yeah.
We're talking about bone health here. The standard measurement to see what your bone is a DEXA scan. So for me, it's just like ordering anything.
And it seems like it's pretty readily available and it's a safe test and gives you really great insight into what your bones are doing. So
I think the caveat would be that there are criteria that even insurance or Medicare or other health systems across the world might have that would be your threshold or cutoff to approve a DEXA. However, at-risk populations, patients, maybe it's a 30-year-old female who unfortunately got breast cancer, was put on a medicine that will impact her bone health negatively.
Or had a nephrectomy.
Right? Then those patients who are on hormonal treatments or anti-hormonal treatments for other diseases, they're higher risk. And those would then qualify them if they're not a 50-year-old female. And so I think the point is, patients out there watching this video, if they think they're at risk because of a risk factor, a family history, maybe they stopped menstruating early, something like that, then they need to talk to their primary care doc about it and say, hey, look, I think I have risk factors for osteoporosis, osteopenia. Can I get a DEXA? Mm-hmm. And that's the goal, right?
And having a hysterectomy and having your ovaries taken out at a young age is a major risk factor for developing osteoporosis. And for you guys out there, if you get prostate cancer and get put on some of the drugs that block your testosterone, okay, to treat that disease, you're also subject to potentially developing osteoporosis. Yep. So there's a whole variety of causes that it's really important to talk to your healthcare provider about to find out if you are at risk for this, perhaps long before you reach those threshold ages we've talked about, 50, 60, 70. I mean, you might want to consider if you have any of these other healthcare issues, because those are the people that slip through the cracks, that come in and all of a sudden we're really dealing with somebody that's got very severe osteoporosis.
Yeah. So we're all about empowering people to take charge of their healthcare journey and not be afraid to ask for things that might help you, to just own your journey. And when that comes to bone health, it could be something as simple as asking for a DEXA scan as a starting point. So thank you for that.
I think the follow-up to that, Rita, is that doctors are very pressed for time in clinics today, and they may not be thinking of all the other aspects that are out there. So you do have to be your own advocate if you think you're at risk for it. I know that in my clinic, we take x-rays of most patients to get a baseline understanding of their anatomy, their structure, and any potential problems they have. And many times I look at the x-ray, I go, that may have osteoporosis, and that triggers me getting the bone density test. So by being an astute clinician and using the information that we already have in a plain x-ray, we often can trigger that. So We're a group of spine surgeons here, and I just want to. Why do we care so much about osteoporosis? And I understand health and preventing fractures, but as surgeons, why do we care about osteoporosis?
Well, because having thin bones or osteoporosis greatly affects the success of our surgeries in a nutshell. And if you have very thin bone and you're going to have elective surgery, and we plan to do a fusion, for example, it tends to affect, if you just have a ruptured disc and we take it out, it's probably less affecting of that because we're not doing a fusion. But the health of your bone determines whether or not the fusion will take. It determines whether or not the instrumentation we may use, screws and rods in the common terms, will hold in the bone and fail. And there's been many, many studies show that people that have osteoporosis and low vitamin D3 levels have loosening of the screws, have lower fusion rates, and have more complications and more repeat surgeries. So we have really become very focused on trying to prevent those issues by treating the bone prior to surgery. If we have an opportunity, we're talking about emergencies here, where we can treat you with new medications and treatment protocols where we can actually improve the quality of the bone to try to prevent those complications of surgery. And that's why we dread complications as surgeons. It's the worst thing we can have for us and for you, obviously. But we try to prevent those, and we have slowly but surely moved to the area where we actually can help slow down and decrease those complications.
100%. I mean, the catastrophe that can happen from weak bones after a major spine surgery, or even a small spine surgery. I think you said it earlier, any surgery where implants are going to be placed, and implants meaning the screws or the rods or some sort of cage, that's going to put forces on those bones. And if those bones are sufficiently weak that those even moderate forces cause a fracture, a collapse, or deformity, where you were from before the surgery, you may have had a short-term good outcome, but then when the fracture or the problem happens due to osteoporosis, it's way worse than where you started. There's a list of things that we look at spine surgeons that we can modify. I can't change your gender. I can't change the color of your hair, but there's nutrition and there's smoking status and osteoporosis. These are modifiable risk factors. That's what we talk about when we talk about trying to prevent complications, trying to increase optimal outcomes. We just want the best thing for the patient. And what I constantly do this. I did it yesterday in clinic. You spend 20 minutes basically bargaining with the patient. Like, I'm trying to get you to help in your own success. And by doing that, we have to delay your surgery a couple months, prepare your bones for this operation so that you have the least chance of a complication. Could you still have one? For sure, anybody could. But what we know now is preventing or pre-treating these patients that maybe have poor bone health is so much better than trying to treat the complication, that it's so critical in our workup now. And it's 100% of the time, I think you said that too, 100% of my patients that are going to have an instrumented case, they get a metabolic bone workup, and it's critical to the success of the operation.
Dr. Carlson, are patients scared of treatment for making their bones stronger before surgery?
I found very few are. The medicines, we don't need to get into the weeds on all the types of medicines we use to pre-treat, but they're very safe. They have a very good safety profile, and they work very, very well. And we know if we use those medicines before an operation like this, that our complication rate goes down substantially. And sometimes those patients will stay on those medicines after surgery, up to a year, sometimes longer, and we can track their bone health long term. I think what happens is, like I said, the 20-minute conversation is more wrapped around, they're in a lot of pain. They're in our office because they want to have a treatment to fix their leg pain or whatever it is. And now you're talking about delaying it 3 months.
Yeah.
And, back to where this all started at the beginning of the story, this cascade of losing that bone started 20 years ago, 30 years ago, maybe longer. And so now what we're trying to do is, on the front end, with panels like this, educate our population, keep those bones healthy, because we have the same exact patient, the same exact age, the same exact medical problems, have great bones. And we don't know why. And you'll see that some of them can have the surgery right away, and they're very happy because they can get their pain gone, and they're excited, surgery next week, okay. And the other ones you're having, it's a lot of counseling, it's a lot of expectation management. But in the end, they're still very pleased if they get through it without that complication.
We're trying to raise the expectations of all the patients that look at this panel, that they demand better bone health. And that whether you're having surgery immediately or have a lot of pain or whatever, we want to raise the standard within the medical community to look at bone health seriously and make sure that every patient is treated to prevent all the things we've been talking about. And it's no coincidence that if I have to do surgery on a 30-year-old person and put screws and rods in, I rarely have the screws pull out or fractures or failure of the fusion. But it's not that case with a 70-year-old. That's why bone health and the quality of the bone is so important in everything. So we really are trying to educate the population in a way that you all expect to have your bone health looked at. And I've been in Brandon's situation many a time where it's like, let's make a deal with the patient, where what I think is best for the patient when they're in pain, try to get their bone better. Often we have a struggle to convince them that. I may have to send a pain manager or do other things to buy them through until we get 3 or 4 months of treatment in so I can get a successful surgery out of them. And 10 or 15 years ago, we were really at somewhat of a pickle with this because we did not have the treatment regimes that we now have today. So I can understand 20 years ago when we only had 1 or 2 drugs and calcium and vitamin D to treat this problem. But now there's been miraculous advancements in the science of this. There's been a lot of smart people look at bone metabolism and how the bone works and how it heals and how to maintain good bone that have resulted in somewhat of a renaissance of wonderful things we now can treat patients with, where there's no excuse for us not to pay attention for this. Yeah. And so that's why we're talking to you to say you should raise your expectations and say, gee, whoever your healthcare provider is, please ask about checking your bone, just like your glucose we talked about earlier. It's very, very important for you.
Yeah, no, I think that's critical. And I think making sure that we're doing what we can, which is complete nicotine abstinence, which doesn't just affect bone, it affects every aspect of our health, but appropriate alcohol intake or no alcohol intake, appropriate dietary sources of calcium, vitamin D, and supplementation as needed are a minimum that people should be doing. And then the question is, where do we go beyond? And then the pharmacology that's available is important. I want to talk a little bit about what bone is and instrumentation, how it impacts it. And when I look at the spine and when I look at the bone that we're trying to put screws in, it's like a piece of styrofoam. And you look at a piece of styrofoam, and you've had it in art class where you have this piece of styrofoam and there's little cells in it. And what we do with our instrumentation is either we put something on the end of it so it'll support the spine, or we put a screw into it. And just like you put a screw into drywall, if the screw starts toggling, it strips and then pulls out of the drywall. What can pull out of the styrofoam? And so what we're talking about is having enough strength of those cells in your styrofoam, your bones, that it's able to hold the screws of the instrumentation. And I think that with artificial disc technology coming out, it's really critical because we're just putting implants in, really laying on the end plates or the end of the bone under compression. And if they subside, it changes the alignment. And that's the big benefit of modern spine surgery, is that we're able to realign or appropriate align the spine to have the appropriate curvatures that are normal. And when you get a fracture or subsidence, then you lose that, which then leads to the failure of the surgery, which is why this is such a critical topic.
This is why both of us feel strongly, and Tom does, that we need to make the bone as good as we can prior to surgery. And it's like putting a screw into a piece of balsa wood versus a piece of oak. It's the best analogy I can use. One of them might put it in with 2 fingers, and I've had many a patient that you could put a screw in with 2 fingers and we know we're in trouble. When we didn't check the bone in the older times, 10 years ago, and I said, boy, this may not hold. Well, I'll do a scoliosis patient that's 18 years old, and I've got to sit there and get a shoulder injury, put a screw into the bone, okay, because it's so hard. And it's literally can be that difference from somebody 30 through somebody 70. So we have to make our substance, the spine, in our particular case, or it doesn't matter with a hip fracture, putting a pin into it if you break your hip, we've got to make that bone as absolutely strong as possible. And that will decrease the chance of the screws coming loose and get a better chance of the surgery being a success. And it's not just unique to us. Like I said, if you come in with a fractured hip and we pin it, okay, because we have to, it's an emergency. If we don't do it, your chance of having a real complication is quite high. But if we fix it, we can get you up and mobilize you and do things. We still should start you on some sort of medication that will build that bone, because more recent studies have kind of shown that even that's effective in improving your bone quality to prevent eventual failure. So there's a lot of things to consider. Even when you've had something like a surgery of your spine or a broken hip, it's probably still beneficial to consider treating the osteoporosis, which you probably should have done 20 years ago. So you got to keep that in mind. We have to be very proactive on this.
Because we're doing so much disc replacement work and surgery on young people with this minimally invasive techniques, which is really wonderful because we can fix one little segment of the spine, is that we're checking bone density on people at younger and younger ages. And what I've discovered in my clinic, and I'm interested in your observations, is that there's an epidemic of osteoporosis. There's an epidemic of osteopenia in our country. And my question to you is, why do we think that's happening? And what should we be doing about that?
Well, as I said earlier, remember that vitamin D deficiency can cause rickets in children, which are 8, 9, 10 years old, and make their bones so soft that just walking around will make it bow, and that's how they get their bowed legs. So it's no surprise to me, with all the things we've talked about, diseases of the kidney and liver, which can start very early. We have a lot of people that have diabetes now. It causes high blood pressure, kidney failure, liver disease, all sorts of things. And all those things can disturb the vitamin D and calcium metabolism, we call it, or how they work in the body.
Plus caffeine and colas
and drugs. All these things can lead to poor bone at any age. Okay, so or people that have, there's a lot of other diseases. For example, men can have deficiency of testosterone, low T, as they call it on TV. That can lead to bad bone. And so it's no surprise that I see a lot of these people. We just did a study where we looked at children as a group, and we saw that basically they seem to have a dip in their bone strength between the ages of 8 and 12 while they grow to an adolescence because they have such rapid bone turnover. Their T-scores or DEXA scans show softer bone, as do their CAT scans. And so it's not surprising to me to see these people. And when somebody comes in and says, "Oh, I drink 4, shots of whiskey a day," well, they're probably going to have bad bone, even though they're 35 years old. And so all of these things really are beyond the core of what we think of most osteoporotic patients are. That's the 60-year-old females. It can happen at any age. And, we have to be aware of that as practitioners and also maybe as patients to look for that.
Yeah, so multifactorial. And I think there are a lot of really smart endocrinologists and clinicians still trying to figure this out, but you are 100% correct. The prevalence of osteoporosis is on the climb, and we know that that's partially related to our population living longer. But as you mentioned, and I've seen this as well, you're also seeing it in younger patients. And there's a lot of reasons, and many were already said. Some of them we think we would think would be innocuous or it shouldn't be such a problem. For example, young females who go on birth control, they change their hormonal cycles. And that hormonal cycle is critical to maintaining bone health. And we don't realize that that's actually starting that cascade. And it won't be when they're 25 or 30 or 35. It'll be when they're 60 that the end result happens, but it's starting that decline early. And then you're seeing when they're 40, getting their disc replacement surgery or whatever you're doing, you're checking their bone density and you're like, gosh, it's low. Why is that? Medicines. I've seen a lot of adverse medication effects for autoimmune disorders. Dilantin.
Seizures.
There's a lot of them that seizure disorder, for example, that's a great example. You got to take that medicine. But the side effect of that medicine is that 5-10 years later, your bone density is going to be going down. We see males and females, autoimmune disorders being put on methotrexate. That can affect bone health as well. So medications, there's all these, and not to really like to really look at the forest, not the trees. It's so many environmental factors. And then there's genetics. Like some of us are just predisposed to not have as good a bone. We don't know why. And that's where all of these other things that, we talk about, being healthy and proper diet and all these other things are just so critical when we're young. Because this is a silent disease that is walking in and out of our doors every day that no one even knows they have until they fall and break a hip. And then it's too late. I did a study on this, actually. Lumbar fusion patients, almost 300 of them. We studied and looked at their bone densities. Over 2/3 of them had metabolic bone disease.
Was that men and women?
2/3, yes. All comers. 2/3. I mean, it's not a coin flip. It's like the odds are against you to have bad bone. And so that's why it's just so important. We hope to educate that you got to think about this stuff early. And boy, if you're going to a clinician to get an intervention related to your bones, whether it's a total hip, a wrist injury, a spine operation, you should ask about bone health. Anything.
Just a fall.
But even just an elective total hip, you should ask about bone health. because those are the kinds of surgeries too. Like, we're spine surgeons and we think about the spine, but I know my colleagues, when they're putting in a hip replacement and they're tapping the stem in and the femur just splits, boy, that's a long day. And that's a lot more pain for that patient, and it's a bad outcome. So just talking about bone health and keeping it in the front of your mind, because it is so silent. Nobody knows they have it.
Let me put this in real terms for the audience. In 1900, the average man lived to be 46 years old, the average female 47. We did not have to worry about osteoporosis back then. Social Security is set up to get your benefits at age 65 because by 1930, the average person lived to be 54. So now we have an average woman living to be 84 and a man to be 82. So we see this much more commonly in an older population, which is what we would expect, because we live so much longer, so much healthier. So it's something. The second reason why I think we see it more is because we surveil more. We are doing more DEXA scans and more studies. It's just like ADH, and things along that line. We're seeing more disease because we're looking for it more, because we're not looking in the dark and burying our head in the sand to look for osteoporosis. More and more people are actually testing for it, and so we find it more. So now we find out, gee whiz, we see it all the time in our office, and we see it more commonly with these things. And so I think that's one of the big reasons why we're seeing an increase in instances, because we're actually testing for it more. And us as orthopedic spine surgeons or orthopedic neurosurgery spine specialists, we look at x-rays, 100,000 of them, and we can almost look at it when we have a good technician and say, oh, that patient's got osteoporosis. I'm on a DEXA scan, but we're kind of unique because we're orthopedic surgeons and we look at bones every day. But I do think that as knowledge has been percolated through all the different doctors and providers around the country, there's no question I think the DEXA scans are being done more frequently, hence why we're diagnosing it more frequently, which is good. It's a good thing.
And so do patients who need spine surgery and have osteoporosis get treated by their spine surgeon for their osteoporosis? Where do patients go? What do they do with that?
Well,
we have a unique situation.
We're kind of the wrong people, all three of us, because
You're the right people to
but it depends.
It's okay.
I mean, some of our places, like our centers, are set up to deal with this and either treated within our systems themselves by people we have that are experts in it, or we have people that we know in other places where we know there's somebody that specializes in this and gets you the right treatment specialist. Some of the primary doctors treat this perfectly well and are aware of it, particularly the more new trained physicians. I think a lot of the medical doctors are trained with this. Like, for example, my medical doctor knows about it very well. And I think there's a lot of other healthcare providers, nurse practitioners, that also pay attention to this. It just depends on where you live and the facilities and experts in the area. The ultimate top of the pinnacle, of course, is an endocrinologist. But it's sometimes they're really, in my practice, reserved and are available for really severe disease where T-scores might be -4, and we see that. Or they might have other diseases with their parathyroid gland, for example, where it makes their bones get washed out. So the bottom line is it depends on where you are. Mm-hmm. Part of our educational process is to let you know what to look for. And our hope is in the future that we will be able to really have available people across the country that can treat this if your family doctor or somebody doesn't do it.
I think another piece of that is, we're passionate about it, obviously. And we have centers that have an infrastructure in place to offer this to our patients and get quick treatment to try to get them to their surgery as soon as they possibly can. Again, being that we're biasing towards trying to have the best outcomes and trying to give the best care for that patient. What we're also doing, though, is we're very actively engaged in societies, different spine societies, why we're here at NASS, why we're even doing this panel. And we're educating our peers. And we're trying to set up this infrastructure across the nation in different centers and showing them the tools that they need. Hey, look how easy it is if you have this provider in your clinic or in your spine center, or these 5 providers in this one city can use this one person, and you've set this infrastructure in motion. Well, then, just as Dr. Dymar said, that's when you start to see immediate increased utilization, a change, and decreased complications. So we're trying to move that needle. We're really trying to make this a stronger message. We know it's out there. People know it isn't. And what happens is there's barriers. Sometimes clinicians have barriers, and it becomes challenging to get the patients the care that they need. So,
and spine societies that we're all members of, they have been profoundly receptive. And a lot of in our courses we teach on this have become more and more attended by spine surgeons. whether neurosurgery or orthopedic surgery, that are really interested and think this is an important thing for your treatment. And so we've really done, I think, a better job over the last 5 or 6 years of getting the word out to a lot of different surgical specialties that treat spinal disease, to actually have us pay attention to it in a more treatable manner. And we often will tell these people how to set up. Look, we didn't have really good treatment programs 5, 10 years ago. We've worked hard over the last decade to get in our nurse practitioners, our PAs that will screen and treat the initial treatment of this on up a kind of a tier to how much treatment you need. We've worked hard to get those established at our center. So it does take a lot of work on the provider's part to set up our centers, but little by little, we're making a nationwide effort to do this. And this is part of our effort.
Worldwide, really.
Worldwide.
I mean, yeah.
And so patients can, when they're selecting a doctor or looking for the doctor to treat their spine condition, they can look to see if the center that they're going to has one of these programs that looks at bone health in addition to their spine problem. But is that what
I think that's hard to say that that's going to be clearly identified, but it's ideal. I think it's also an evolving field that not every clinician is set up to do that today, but I think it's heading that way.
And you as patients, you can ask that.
That's the goal.
That's the goal.
Yeah.
That's why we're doing this, is so you put it in your treatment algorithm or plan in your head that you will say, look, I'm having major spine surgery. Should I have my bone checked? I'm 60 years old and my mother had it.
Yep.
And I have Northern European female descent, so to speak. And those are classic for this problem. And I spoke to packs of cigarette a day. Am I at risk? Well, yeah, you are at risk, and it's something that should be done prior to any surgery, that you should address those health issues, or you're not going to do as well as you could.
And Dr. Dymar, for some patients who maybe don't have risk factors, they should maybe ask for it also, because sometimes you're surprised, right?
I think that's the bottom line. If a patient learns about this enough that when they're researching their own condition, they're coming to us with questions that are very meaningful about the treatment we're going to offer, and this should be in that dialogue. It should be, well, what about my bones? Are my bones good enough to go through this?
Is my blood good enough?
That's easy
Is my
enough.
blood pressure good enough?
And if that even triggers a clinician who maybe doesn't have the center, the infrastructure we have in our centers, to just say, oh yeah, that's a great point. Let's check your DEXA. All of a sudden we're moving the needle. And I think that's an important message.
I think it's important to check as a regular health issue for people, but especially if you're going to get implants put in your spine. And that's critical. But I think it should be much broader than just people having spine surgery.
100%.
But it's something important. So to try to wrap this up, I'd like you gentlemen just to comment a little bit on the current state of pharmacology. I mean, we're blessed to be living in this biocentury where 8 of the 10 top-selling drugs are done through recombinant DNA work. And we have such powerful genomics that has helped drive what to do. Can you gentlemen talk a little bit about what we have that's powerful today to help?
Let me give my synopsis, because he's actually the master. He knows.
I was going to say.
Well, no, but I'll just give you the 3 categories and then let him kind of, because his description of how they work is phenomenal. But what I tell my patients are, there's the basics like calcium and vitamin D. There's some medicines that we have that help you stop losing bone. It's just slowing down the loss problem. And there are 3 medicines we currently have that help you grow bone. And that's where I start. That's the baseline conversation. And many of the surgical patients, if they're going to have surgery and they have weak bones, they're in this 3 drug category. And so I'll just let him talk to you briefly about what they actually do in the body. But most of the patients, that's the knowledge they need. Oh, I need one of the ones that gets my bones stronger. That's really what we're going for.
Well, that's pretty good, actually.
I live in Kansas City. I gotta keep it simple.
I live in Kentucky. I have to. I try to. I think we all have ways we explain as physicians differently to our patients, and sometimes when we talk to patients, we think that we're talking to them in common language when we're not, and you have to be, as a patient, say, well, I don't understand that, doctor. Can you explain that a different way? And we actually have a repertoire of things where we have about 6 different ways we can explain the same thing to you, hopefully. Because different people understand different things because we all come from different backgrounds. But what he said is correct. We have medications that have been around for quite a while that will slow the bone loss, but they don't build bone. So if you come in and your bone already is really severely osteoporotic, a T-score we've been talking about, which is just a way to measure it, of -3, probably some of those bone reabsorption drugs aren't good enough. They're not going to make you build bone, which is what we need. We call that medical term catabolic, bone goes away. Anabolic, we build bone. Anabolic steroids, you've all heard of those. That's what all the weightlifters use, probably a lot of other people in sports. And they make your bone stronger. They actually make you produce more bone, which is what we really want when we do spine surgery. So what he said about if you're really poorly, you have really poor bone, and we plan to do an elective surgery on you, we're almost certainly going to have you put on one of those drugs that involves building your bone, okay? And those drugs are teriparatides and one called denosumab. Again, sorry about the terms. Those are not, we'll have to use generic data. They slow down your bone loss, but they're slightly anabolic. They slightly build bone. The teriparatides, which are just like the parathyroid hormone here in your gland, they make you grow bone and actually build bone. Those are what we prefer to build your bone for surgery because they actually make it stronger so it holds the screws better. The final one is one called romosozumab, which is a new product on the market, which works entirely different in that it blocks a certain chemical in your cells, and it really slows down the reabsorption of bone and actually makes the bone cells, the osteoblasts that Brandon mentioned earlier and Tom mentioned, they actually make those somewhat proliferate and make more bone. So we have 3 different drugs now, 2 parathyroids and the romosozumab, that actually will increase your bone mass. And some of them are rather dramatic, like within a period of 3 to 4 months, we can increase your bone strength by 30% and bone turnover by 30% as is measured in your urine, and make your bone stronger so that now we can do successful surgery, the screws will hold, you won't fracture the bone, and we can get a successful result. Those will all come about really in the last decade, which is what I was alluding to earlier. And I think those have been a quantum leap, like the TV show, in what we're able to do to help your bone get better before surgery, or even if you don't have surgery and you've had a fracture, you should be put on those bones to make sure you don't get fractures. Now, those have to be treated very specifically, and then we may treat you with one for a while, and then after 3 or 4 years, we'll switch you to another for a while. And so we have to cycle that because we slow down the loss of bone and we build bone. It's just like a scale to make you have a positive scale to make more bone. And so we alternate things back and forth over really the rest of your life treatment plan to keep you from getting future fractures. Future fractures, if you have one compression fracture from thin bone in your spine, you're going to have a 50% chance of having another one within 6 months. And if you have another one within 6 months, this is without treatment, you're going to have a 100% chance of getting another one. If you break one hip due to osteoporosis, odds are you may have another hip break unless you treat this problem. And so we have these drugs, and we really carefully monitor them that we can gradually build the bone in the fashion I just talked about. Does that explain?
Yeah. 100%.
And so when a patient gets on one of those medications, they build the bone, they have a successful spine surgery, what happens to the bone after that?
We continue to treat the bone forever. Yeah. Because the problem is if we stop treatment, the bone will get thin again.
So patients will expect to be treating their bone for the rest of their lives.
People are probably familiar with one, bisphosphonate, which is the first drug that came out 20 years ago to treat this. People were put on that for 10 years. It slowed down the reabsorption of bone. But the bone got brittle. Because remember I told you the bone remodels every 10 years. It builds bone, resorbs bone, builds bone, makes new strong bone. So if you just prevent the reabsorption, what happened? People got fractures. So now we know we have to build bone, slow down the loss of bone, build bone. So that's why it's a lifelong treatment, in my opinion.
I think to your question, if a patient is going to be pre-treated, they should expect that they'll be on a treatment regimen for an extended period after that. Certainly
2 years.
Certainly with those 3 medicines, if they went on one of those, we know that keeping them on those after the surgery, especially in spine fusion situations, things like that, or fracture healing, things like that, to maximize the result and keep that, I call it the bone machine. Keep the bone machine turning, right? And then after that, you convert them to another medicine to maintain what they gained. So you're building it all back up, but if you just go right off, it'll fall back down. And that's the hard part to translate to patients because it's 12 months after they had their surgery. Their leg doesn't hurt anymore. They're very happy. And now you're telling them like, but now I need you to go on this other medicine for a long time,
Yeah.
you know, and that's the constant monitoring, because the DEXA scan might change in future years, and then you could actually go back on one of those 3 medicines to build back up, because the ultimate goal, the punchline of this whole thing, prevent fractures.
Right.
No fractures.
No
Right.
fractures.
Right. X
And
fractures.
remember, you're on high blood pressure medication the rest of your life, or you're taking
that.
potentially insulin if you're diabetic, or some of the new GP1 blockers, we call them.
Right.
And so some of these treatments will be lifelong, but the consequences for just taking a pill or a shot or whatever versus getting a fracture is pretty minimal.
And that's the good news, right? I mean, I think that's
Absolutely.
it's good news. We have a lifelong treatment for this. And
Absolutely.
we talk about in the Spine Health Foundation that your spine care is a journey. It's not a one and done thing. It's a lifelong commitment to caring for your spine and whatever that looks like for each person. And for the osteoporotic patient, it's a lifelong management of their bone health. And there's good news because there's good treatments.
So if we can slow down the loss of your bone by paying attention to your health, which we discussed the interventional things you can do, and even if you have a family history of osteoporosis where it's genetic and you can't help it, we now have effective means of identifying it at any age span from 30 to 80, okay? And we have really effective treatments, medications, exercise, supplementation, diet, change of lifestyle. All these things can keep you from getting a life-threatening hip fracture or fracture of your spine, or wrist fracture, which can be annoying the rest of your life. So we are profoundly optimistic as a panel that we can really affect how you do the rest of your life with this kind of bone, with osteoporosis, which is why we're here talking to you.
What I'd like to close with is just a little advice. And my little pearl for you to take home is that your spine health matters, your bone matters. And you can do things. You can prevent problems by having the right diet, having the right exercise, and avoiding things that leach calcium from your body, mainly diet. And you should be doing proactive things to protect your spine when you're young and throughout your life to optimize your health and your mobility.
I would say to the audience that there is great hope that we can treat successfully your osteoporosis if we can identify it. So I ask you to be proactive patients and ask your healthcare providers to check for your bone health, your vitamin D3 levels, and a DEXA scan, and seek treatment. If you don't get a satisfactory answer, say, well, is there somebody that I can go see, which will be ever increasing as far as us providers, to address this issue. So don't just say, oh, I give up, We have ways we can treat it, and that is so profoundly optimistic for all of us that we actually have a way that we can do something when, not too many years ago, it was kind of a hopeless situation. So keep that in mind and keep the faith, I guess, that we can actually treat these things out.
I think the only thing I could add to that, and that's a great synopsis, is start early. I think that's a critical thing that is very often overlooked. And our population, we don't know why the prevalence of metabolic bone disease, that's probably the best description of this whole thing, is happening in younger people. But that's even more reason that you should keep it in your mind. And when you go to your doctor, do like Dr. Dymar just said and say, hey, what about my bone health? Is this the time in my life to check it, or do we want to check it next year? And being very proactive at a young age can prevent so many morbidity events in your lifetime. When a patient comes in and it's just catastrophic, or they have a fracture and they find out at that time point that they have osteoporosis, it is just devastating to them. And it's already too late. And so the prevention is so much more important than finding out when you're later in life with a fracture. So start early. Just start asking early about your bone health.
And ask for a D3 level. Most of the time, if you ask your doctor, he's just going to order your panel with the blood work. Ask potentially for a DEXA scan. Be aware of your family history. Ask around, see if anybody in your family had osteoporosis. And make sure that if you have a lot of other illnesses, that you ask whether or not these can affect your bone health. Those are simple things just to kind of jot down that you can ask your doctors.
Well, and I'd like to say in closing, this has just been such a fascinating conversation to think that we're on this panel with spine surgeons and the range of things that we've talked about that cover your entire body and your overall health is just remarkable, that it can start from your spine, that conversation can start from your spine. And why does that matter? Because so much of what we educate about at the National Spine Health Foundation is that if you don't take care of your spine, you can't keep moving. And staying in motion is the best way to stay alive. And keeping your bone health, keeping your bones healthy, keeping your skeleton strong, keeping your spine strong is bone health. And so that is why we've talked about so many incredible things today. I just want to thank these healthcare heroes who put the best of science into practice every day for their patients. They're so passionate about getting the best outcomes for their patients. And one of the best ways we can do that is to educate you on what your treatment options are and how to go about finding that. So I want to thank Dr. Carlson, Dr. Daimar, and Dr. Schuler for being our healthcare heroes. Thank you.